Hello, welcome back to Neurospicy Nursing. Today we're going to go over kind of the basics of the heart defects. I will be putting out lectures on each of the heart defects individually, just so that you guys get like the full nursing care and how we treat them just on itself, everything that you need to know for test for each of them. But this is kind of just an overarching of kind of everything to start. Okay, so the first thing that we need to do before we touch the defects is learn the three basic kind of hemodynamic concepts. The first one is preload. So it's the blood returning to the atria at the end of the diastolic volume. So I like to think volume, more preload equals more stretch. So the more preload you have, the more stretched out that atria is going to be. Afterload is the pressure that the heart is pumping against, or the aortic pressure. Kind of start to think resistance and obstructive lesions, which we're going to learn in a little bit, are going to crank up the afterload. And then contractility is the force at ejection or contraction, however you like to think of it. But this is your heart squeezing, is how I like to remember it. All right, so the first thing that we're going to go over is left to right shunts. These are your pink kids, so no cyanosis here. They tend to have fluid overload though, and a lot of congestive heart failure patterns. And then these are the three main ones. I'm about to go into them a little bit in depth before we do the in-depth 5-slide fix on them specifically. Okay, so ASD. This is a hole between atria. So there's a lot of blood flow in the lungs. All right, so you can hear crackles, that sort of thing when we're talking about ASD. They tend to have kind of like a soft murmur, or you can hear a split S2, and they're going to be asymptomatic. We're going to go a lot more in depth in them, I promise. All right, PDA. The aorta and the pulmonary artery are like the connection between them. They have that in the womb. It's going to stay open instead of closing like it's supposed to. They have a very kind of mechanical sounding murmur, and they tend to have bounding pulses and widened pulse pressure. I'm going to talk about what widened pulse pressure is in the lecture on PDA specifically. All right, VSD. Most common congenital heart defect is VSD. They have a super harsh systolic murmur, and if their VSD is not treated, it can actually lead to CHF. So just make sure that you know that, and it can actually close spontaneously. All right, into obstructive lesions. These are our pressure overload issues. So again, we're thinking that afterload. You can have left ventricular hypertrophy, sometimes even right ventricular hypertrophy. But the two main ones are going to be cortication of the aorta and pulmonary stenosis. So cortication of the aorta, we're thinking the narrowing of the descending aorta specifically, and they'll have upper body hypertension, lower body hypotension. We'll talk about that in the next lecture, but they can have a risk for a stroke or aortic rupture. Pulmonary stenosis, we're looking at an obstruction of the right ventricular outflow. So they have an ejection murmur systolically, and in severe cases, they can end up with cyanosis. All right, into the cyanotic defects. Okay, these are your, instead of it being right to left shunting, you're shunting, or instead of being left to right shunting, you're shunting right to left. So these kids will turn blue, they will have cyanosis, and it's because of that pulmonary blood flow mixing. So tricuspid atresia is one of the first ones. They don't have a tricuspid valve, which means they don't have a right atria to right ventricle blood flow. So they need ASD and VSD to technically survive. They'll have a lot of cyanosis because they have one ventricle, which is obviously not normal for the human body. We have two. All right, pulmonary atresia. They don't have a pulmonary valve, so there's no proper blood flow to the lungs. Um, and they need a PDA for proper oxygenation. All right, TGA. From the aorta, the aorta from the right ventricle, they have a PA from the left ventricle, and they have their own parallel circuits. What I mean by that is oxygenated blood is going to flow in a circle, deoxygenated blood is going to flow in the circle, but the deoxygenated blood is never going to become oxygenated. Two separate circuits of deoxygenated blood and oxygenated blood. So, we need mixing, right? That's how we go from deoxygenated blood to oxygenated blood. That's not happening here. So they will be cyanotic at birth, and they'll need a specific surgery that we'll talk about in the next lecture video. All right, tetralogy of Fallot. This is a combination of four different defects, okay? A VSD, pulmonary stenosis, overriding aorta, and right ventricular hypertrophy. They end up with TET spells, which baseline how we treat it is going to be knee, chest, O2, and morphine. We're going to talk about it a little bit more though. All right, and then nursing care patterns. Growth and development. You're going to see a lot of poor feeding, fatigue. You can even see FTT. You'll also see left to right shunts. You'll see heart failure signs and symptoms like tachypnea. We talked about a little bit of it in med surge, how they will also have crackles, that sort of thing in their lungs if they have pulmonary edema, that sort of thing. They can also become diuretic when feeding. If they have cyanosis, we're going to teach prostaglandins usage, needed chest, and then we're going to cluster care just to prevent any overstimulation. We're going to teach the parents, they have medications, they have to check them regularly, make sure they're doing daily weights, because remember, daily weights are better for fluid volume overload checking rather than eyes and nose. And then if they do have a catheter that has been inserted, post-op care is keep that leg straight, and you're monitoring for bleeding, and then you're monitoring distal pulses. All right, and that's everything for this one. Thank you. And make sure you look out for those different videos on the different types of, or the main types, I should say, of defects on their own. They're all going to have their own video. And yeah, thank you guys so much, and I'll see you in the next one. Bye.